Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, everyone. Dr. Eric Westman here, and it's my great pleasure to introduce a colleague who works at a different university, Dr. Sue Wolver. Sue, can you introduce yourself to imagine that you're at a support group with my patients around? How would you introduce yourself?
First, I want to say it's my great pleasure to be here because the people in the room may not realize that I'm only here because of you. You're my mentor. I've known you for more than a decade. And in fact, this May, 11 years ago, I came to visit your clinic, was blown away by what I saw. And I spent a Tuesday and a Wednesday with you. Saw more patients in those 2 days that lost weight than I had in the whole 20 plus years of my career to that time. And that very Friday, I started my own clinic 11 years ago. So it is my pleasure to be here with you. How would I
Well,
introduce myself? I'm sorry,
yes,
go ahead.
yes. I was just going to say it doesn't seem that long ago. My take now is that time just goes by fast. But
Yeah.
yeah. So where are you? Where do you work? What's your position at the university and all?
Okay, so I work at VCU Health System, but my what I talk about today are my own opinions. And I've been there for going on 21 years. The first 20 plus years of my career, I was a primary care doctor. And about maybe 12 years ago, when I started to gain weight myself, I kind of had an epiphany that maybe it wasn't that my patients weren't following my advice, maybe my advice wasn't so good. So I kind of looked at my personal journey and figured out how to lose some weight. And I had tried many, many things in the past and remember thinking, if I don't feel hungry, I'm not doing it right. And nothing I ever did work. The harder I tried following my own advice, the more weight I gained. And so I thought, let me try this Atkins thing. And I remember sitting downstairs Googling, exactly how do I do this? And I looked through it and I'm like, that seems so hard. And the most incredible thing was I was able to lose weight and not be hungry. And that was such a shift in thinking for me because I always thought I had to be hungry. But in retrospect, knowing, about how the body works, hunger makes you doomed to failure because it's not biologically plausible to have hunger and to continue on. Our brains just don't work that way. And I was able to lose about 15 pounds, and I've kept it off all those years. And had I not made an intervention, I'm sure I'd have at least 40 pounds to lose now. So it was so easy for me. I thought, well, let me try this with a few of people like you, my patients. And they were very eager to lose weight. I always talked about, eat less, move more, wasn't working. So I said, well, you guys want to try something with me? And they were like, we're in, we're game. And after meeting with you, I sat them in what was the old file room, which used to have files, but now we were moving to electronic records. So it was a big empty room. And I got a flip chart and started drawing some things. And 11 years ago, 11 years now, we've helped 3,000 patients, primarily with a low carb and for some people ketogenic diet. And I've had more fun in the last decade than I did in all my years in medicine. So
Well,
I'm an associate professor there. I do a little bit of research, but mostly I run the clinic and try and get the biggest team I can to help my patients.
now what you said went by really quickly. VCU, it used to be MCV. I get these acronyms, and you're in Richmond, Virginia. That right? I mean, I'm just getting it right.
I keep going to schools that change their name. So yeah.
um, but so people often come and ask me, well, you're a Duke. How did they let you be a Duke? And I explained, well, actually, there've been a lot of different diet programs, including the rice diet some years ago, which was like an Ornish diet. And today there are 3 or 4 different weight loss programs that use different approaches. How did a university allow you to do what was, 11 years ago, something radically different than dietitians?
They didn't.
They
I
didn't.
just did it. I had a primary care practice and I had patients that needed to lose weight. And it wasn't until I thought, well, let's see if I can do this, and started with a few patients. And I didn't know if I would be any good at this. And they started losing weight, coming off of some of their medications, and tried it with a few more patients. And I thought, you know, maybe I am good at this and maybe I really like this. And then I had my colleagues in primary care, hey, if you want to send your patients to me, I can work with them. And then they started going into other places in the hospital and other clinics. And to date, we have never advertised our program, not once.
Yeah,
And
no need.
people either Google me and find out about me, but most of the time it's word of mouth by seeing one of my walking billboards, AKA my patients. And they say, hey, how did you lose this weight? And that's how they all come to see me. And when people started hearing about me and what I could do, some of my colleagues thought, well, can you help this patient because they need to have this surgery? Or can you help this patient because they need to get on the transplant list? Or can you help this patient because they have sleep apnea? Or can you help this patient because they need egg retrieval and they won't do egg retrieval on them with their BMI? And just really became a snowball effect. And I really have to commend VCU, which is Virginia Commonwealth University, as they really have supported me. I sort of brought them the evidence by actually just taking care of the patients rather than asking permission to do it, because it was my primary care practice and I was helping people in the best way I knew how. But then it became a real asset for the health system to have somebody who did this, because at that time there was nobody doing medical weight loss. We only had bariatric surgery.
Yeah, well, that sounds similar to at Duke, where I am in Durham, North Carolina, where I did have to ask. Well, I chose to ask my department chair, but I didn't have to ask the dean or anyone super high up, but I asked for just the clinic time, and he looked at me and said, "We have weight loss at Duke," and I said, "What do you mean?" He said, "We have the Duke Diet and Fitness Center." I mean, this is a rich, or have people come to town is $2,000-$3,000 a week, and I explained, no, I mean, I own a weight loss program within the insurance system that actually most people can get access to. And so he said, okay, but just don't lose too much money, because in a university, at least like Duke, us guys out in the outpatient area, we lose money compared to the surgeons and procedure oriented specialties, so that most universities have partnered up with the surgeons, and we have a very different philosophy. And oh wait, so 11 years ago there was no Ozempic, was there? And you were still helping people lose weight?
Lose weight, come off of their medications.
Yeah. Right. Well, we'll get into the medicines in just a little bit, because it's the buzz, and what we do goes back to the 1860s. The Banting diet, and it finally dawned on me. They didn't have apps, they didn't have ketone drinks or ketone they didn't even have electricity, and it still worked. So just changing the food is so powerful. So now that you've been in practice, and what is I don't know, one of the, and we know it helps obesity and diabetes. We've published papers, and you've published papers, or at least one from your clinical experience, which is fabulous. In fact, you have kind of a data background. I kind of remember that you mentioned it, and I'd like to just have you talk again about the getting joy in being a doctor again, because I see a lot of doctors who are not happy with what they do. And I seem to remember that was part of the change that you liked.
Oh, no question about it. Prior to bringing this into my practice, I did what was called the dance. My patients would come see me. Their diabetes wasn't well controlled. Their blood pressure wasn't controlled. We tweaked their medications. They'd go away for 3 months. They'd come back. Their diabetes wasn't controlled. Their blood pressure wasn't controlled. We tweaked their medicine. And I'd say, oh, eat less and move more. And we would just keep doing this dance, and nobody ever got better. And when I say, okay, we really probably need to consider insulin, no one said, hey, great, thank you so much. I feel so much better on insulin. And now it's just every day I feel like I cure cancer, because really obesity is like a cancer. Not only does it cause a number of cancers, or is a huge risk factor for a number of cancers, but it really metastasizes into every aspect of a person's life. Their joy, their their sense of fulfillment, their ability to play with their children, get on roller coasters.
Yeah.
We always ask patients to tell us when they come in a non-scale victory that they've had since the last time. And I mean, some of them just make me cry, you know, going on an airplane and not having to ask for a seatbelt extender. I mean, things that people who don't struggle with their weight take for granted really just affect everything in a
Looking
patient's
around
life.
the
When you
room,
see,
going into the room, looking around the room to try to find the chair that would not only would fit, but would take their weight. And, you know, the ability to cross your legs. One person looked at me, a patient looked at me and said, "Look," and she crossed her legs. I said, "What?" I said, you know, because I was kind of new to it. She said, "I can cross my legs." And someone
tie their own
I,
shoelaces. I mean,
this bone, I can feel my bone. And I'm, you know, so I also lost about 20 pounds on the low carb diet, but followed the signal that my patients were sending to me. They lost weight on their own, read the Atkins book. So I don't have a massive weight loss story. And it's kind of like you, I'm learning. In fact, it might be a little bit of an advantage because I'm not colored by my own personal experience too much. You know, there are some doctors who lose a lot of weight, they become advocates and zealots and obesity specialists, but there must be some inherent or unspoken bias toward the way they did it, I think, but I don't know. Tell me a story about diabetes reversal. And if you're watching this and you have no idea what we're talking about, we're talking about a low-carb keto diet that's been around a long time. It's not the ketogenic diet for epilepsy. That's very different. And you help people by just changing the food. And yes, we can reverse not only obesity, but also diabetes. So people might say, oh, well, okay, so someone has a little bit of diabetes, you put them on this, you know. Tell me a story.
well, for my first, you know, 2 decades of practice, I never saw anybody's diabetes get better. You know, if it did, it was just a little bit. And, you know, quite honestly, I precept in the resident clinic. And so, yeah, I'm working with a lot of primary care doctors. And most of us had just
hang on.
give,
That means that you're teaching young doctors working in the
right, I teach young doctors, right? And
yeah.
sorry about that. But most people have just given up sort of telling patients that there's another way other than just adding medication. And we've taken that choice away from them, making a decision for them that this is something they don't want to do. And so we'll just give medication. And I try to teach my young doctors and medical students that, you know, we're all about collaborative care and agency and, you know, letting patients make their own decisions in this day and age. And we have every right and we should to give them their options. And deciding for a patient that they may not want to do it is not something we should be doing. And so offering them, you know, we can go on this medication or we can change your diet. And it's surprising how many people actually want to change their diet when you actually give it to them and then teach them how to do it. That was my other big problem is I told patients to eat less and move more, which doesn't work, but I didn't give them any true direction or guidance on how to do this thing.
Well, but
And
you
so I
weren't
had to learn myself.
you weren't taught that. Medical
That's what I
school
was saying. I had to learn myself. Nobody ever taught me. You know,
yeah.
I learned teach them a low-fat diet and exercise, and everybody's going to get better. But nobody did. Nobody, myself included.
Yeah, you know, but so if you imagine, yes, people started a lifestyle, and it's in all the guidelines, right? For hypertension, for diabetes, you know, you start with lifestyle, but they're using the wrong lifestyle. So, you know, even the medical establishment and the research establishment teed up, you know, got together this big study of the low-fat diet, you know, with, I don't know, was it 48,000 women, and it didn't work. And actually, we taught people that this was working through a study that it's working, but at the end of the day, it didn't work. I remember going into a researcher at Duke, her office saying, you know, how's the study going? Oh, it's going great. Well, what are the results? People are eating more fruits and vegetables. And I said, yeah, but is there less cancer? Oh, well, it didn't help with that. Wait a minute. So the goalposts have been brought into the process change without the outcome change anymore as a requirement. And yet, so I don't know, the low-fat diet's kind of fading away, don't you think?
I do, but it was interesting. You're talking about this like this was a while ago. There was just something published that just came across from one of the news wires, Medscape or whatever. Food is medicine is a good idea. Why it didn't work. I'm like, why it didn't work is because we weren't teaching the right food as medicine.
Yes. Well, Rob Lustig, our colleague, professor of pediatric endocrinology, I think he's emeritus professor now from the University of California, San Francisco, put it together. It was at an Obesity Medicine Association meeting. I seem to remember. He said, well, Hippocrates said, let food be thy medicine. Now, that was okay, but no, good food is medicine. And bad food requires medicine, which really was kind of brilliant because it allowed for the fact that doctors are using medicines because people are eating bad food. I mean, they call it junk food, and then when you think about it, Hippocrates didn't have to fight the food industry. So just saying, let food be thy medicine, okay, it worked then. But now, yes, you have to be careful about the food. But so tell me a story of insulin reduction. So even if you have diabetes with insulin, you can get off it and fix the diabetes.
I helped one woman in particular was my primary care patient, and she had been on insulin for 30 years, and she's come off of insulin.
Oh, I mean,
I've taken
30 years? No, people will come to me and say, well, doc, I've been on insulin for 10 years. I can't come off it. 30 years. I mean, I've seen this too. I'm just saying this for emphasis. It doesn't really matter how long someone's had insulin, does it?
I recently took someone off of 73 units of insulin in 4 days. And I know you've done the same.
In how long?
4 days.
So 73 units. So just to kind of recap the treatment of diabetes, first you might be told you have pre-diabetes. You might be put on metformin, right? Remember, medical care means medication care. And then when metformin doesn't work anymore, you'll be put on a sulfonylurea or other drug, although those are kind of fading away because it's been found out that they actually make you gain weight. Well, but then you might be put on another medicine like Ozempic or insulin and all that. But once you get on insulin, you will gain weight. And if weight is a contributing cause to the diabetes, the doctors are basically perpetuating the diabetes by giving the insulin. And I guess when you think about it, insulin tells the sugar to go into the cells. It lowers the blood sugar from the bloodstream, but where does the sugar go, right? So if you have extra food around, it's turned to fat. And of course, insulin then stops the fat burning. So 70 units, you start at 20, for example. I seem to remember back in the day when I started insulin, about a unit an hour or something like that. And then you might double it to 40 and to 60. And so this person was on 70 units of insulin, but that took months or years to get up to that, right? And then you stopped it in 3 days? 4 days. Explain this magic. It's not magic, is it?
It's food. Really, diabetes, type 2 diabetes, we should be clear about that, is really, takes genes and it takes food. You really can't change your genes, but you can change your diet. I teach my patients that it's a bit of a carbohydrate allergy. They just can't manage their carbohydrates very well. So they can either take medication to or they can stop eating carbohydrates or dramatically reduce their carbohydrates. Some people that have trouble understanding this a little bit, especially patients that come to me on insulin, I might do the analogy and say to them, people who have peanut allergies, they're like, yeah, they carry around that epinephrine pen just in case they, accidentally wind up eating something that has a nut in it. Yeah. Have you ever seen any one of them stab themselves with the epinephrine so they could eat nuts? He said,
Yeah,
no, that's crazy.
Yeah, that's perfect. Although technically it's not the same kind of reaction, it gets to the point that you're basically treating the foods. But explain how insulin is started with somebody. like even in pediatrics? How do you dose insulin?
Well, I'm not a pediatrician, so I wouldn't know that.
Well,
But
it's carbs, it's servings of carbohydrates, right?
okay, yeah,
That's all I meant, yeah. So
yeah.
that you dose the amount of insulin based on the amount of carbs in the food, right? So
Well, if you're going to be giving short acting insulin, so usually you start with a long acting insulin because you don't have even though you have high insulin levels, your insulin's not working very well, so you have to give more insulin. So you're actually giving a patient insulin, and then when their blood sugars are no longer controlled, then you have to start giving them insulin for the meals that they eat. And you can dose that based upon how many carbohydrates they're eating for a meal.
yeah, so you mentioned something very quickly that I just want to dwell upon for a minute, and that's the fact that if you have type 2 diabetes, your insulin level is already high. And it was in Gary Taubes's book on diabetes, Rethinking Diabetes, that just came out this year. In reading that, he basically said this is unusual for endocrinology. It's a field where typically if the hormone is low, you give the hormone. If the hormone is high, you give something to reduce the hormone. But when type 2 diabetes happens, your insulin's already high. It makes no sense to a traditionally trained endocrinologist to lower the insulin. But in that book, which I think is a fantastic read, it's Gary, quintessential Gary Taubes. It's pretty dense and pretty scientific, but his good calories, bad calories is still a pioneering work. If you have any concern about all the science that got into the low-fat diet, there really wasn't much. But so it turns out that the insulin was used for type 1 and type 2 diabetes before the insulin assay was created in the early 1960s. The radio immunoassay to detect insulin wasn't around. So imagine the surprise. And I went back to read the paper that basically showed that type 2s had high insulin levels. And in that paper, it's almost chilling because they said, don't give more insulin to these people. And, the scientists, this is back in the 1970s. And yet doctors were trained to give insulin to people whose insulin is already too high. So does giving insulin to someone with insulin resistance fix the insulin resistance?
Nope, not at all. And
But,
the thing
but,
is, you
but
just keep giving more and more and more insulin. I've seen patients, on 300-400 units of insulin come to me.
right, when the U100, which is the dilution of it, the strength of it, stops, there isn't enough space to inject it. Oh, no problem. We make U200 insulin now. The U500 insulin, that just blew my mind. That let's just cram more insulin. No, the problem isn't that there's not enough insulin. The problem is it's not listening. Insulin resistance. I mean, it's kind of like going to a noisy rock concert or any concert where there's a lot of noise. Your ears just they adapt and don't hear as much. So that would be like, I don't know, sound resistance. And if you just give more noise because your ears don't hear it, you're not fixing the issue at all. Now, but so my world record so far is taking someone off 600 units. And in fact, I didn't do it. She did it on her own. With so if you're on insulin or diabetes medicines, be careful. If you need to do this with someone, and sometimes I have people text me their results, but this person understood it just like that. She had a glucose monitor or a finger stick, I don't remember which. And by just watching her own blood sugar, she came off the 600 units of insulin in 8 weeks. And I remember 180 units in 2 days from years ago when this guy was basically drinking Coca-Cola or Pepsi, I don't know which brand. It was sugary drinks, liters of it. It was basically injecting insulin and drinking sugar. It's like this. How would a doctor allow that to happen? Oh, but let's go back. In your old practice, did you ever ask anyone what they ate and drank? I never did.
Well, I did a little bit, but I didn't get enough detail.
Well, and
People would
now
say,
that's
I'm not really eating much. I have a sandwich, I have some chips, but I forgot to ask, well, what are you drinking? So, well, I'm drinking
well,
soda all day long. So
in Richmond, if you just say tea, do you assume it's sweet tea?
absolutely.
Yeah, here too. The newcomers who come from the north to train at Duke, I have to remind them, if someone says tea, it means sweet tea. Down here, we say unsweet tea, and it's usually with sort of a unsweet tea. But what about now? Everyone's really hot on these insulin pumps. Yeah, that'll fix it.
So we'll talk about the insulin pump in just a second, but you mentioned something that I think really we need to talk a little bit more about, and those are the continuous glucose monitors. I think that it's such a game changer for my patients, and patients who have insurance can usually get even one free from the company, from their websites, and seeing what you eat in real time, whether you have diabetes or not, I think is just an absolute game changer where
It's
you
and
can
it's so
really see, hey, I
it's
really am what I eat.
it's painless. Even I tried one for a month.
I do too.
I was kind of shamed by these young doctors who'd been using them for years. They hadn't had carbs for years either. It's like, well, okay, I'm going to try it. And so while there is a small needle at the beginning when you inject it, it's so easy to do. Even I did it.
Yeah, it was very painless and
Yeah.
kind of mind blowing, really.
And then you don't have to finger stick at all. You just put your phone over it. It reads it, every 5 minutes or so, depending on the type of monitor. It really puts it puts you, the patient, in charge of the reversal of a disease that your doctors just want to manage. Someone came in, a patient, he said, why are doctors like salespeople for drug companies? Yeah, I never thought of it that way. It's because that's all they know, right? And yeah, CGMs, I wish they were, well, now there is a hospital in North Carolina that gives out free CGMs to all of their staff if they ask for them. And that would be such what a investment in a company or a staff, or, Mark Cucuzella did a couple studies and published one where he just gave out continuous glucose monitors, didn't really tell people what to eat. And people on their own, they reduced the carbs in the food because they didn't want their blood sugar to go up, right? So yeah, I wish they were more commonly or more available. I think I paid $100 for a month when I didn't have insurance. I just went in and bought one. You have to have a prescription still, though. Right?
So there's one that's coming over the counter.
Soon or
Yes, they just said it was FDA approved. So how much it's going to cost, I don't know. Whether insurance is going to cover it strictly out of pocket, how much it's going to cost out of pocket, but one is coming very soon over the counter.
And it's one of these things I need to just put into perspective. If you have to pay a little bit out of pocket to get the information that until now has been controlled by the system, the doctors and all, it's worth a small investment now to not go down that path of diabetes. I mean, I tragically had a recent patient who got lost out there, got eating carbs again, and he came back because he lost 2 toes due to the management of diabetes with medication. Best medical care. It's not like he's living in a third world country or out in rural North Carolina. He's in a major metropolitan area. And so if you settle and manage, you pay a few $100s now so that you don't lose your toes, or the kidney failure and the blindness, all these things. But it's interesting. Most of my insurance pay patients kind of assume that insurance will pay for things that are worth it. And if you go outside of it, it's like you're not I don't know, you're doing something strange, or I don't know, not approved when money came into the guideline process. Gosh, this was when we were young, right? 80s, 90s, and Medicare started having the cost effectiveness analyses and all this. I guess you had to do that, right? You can't just put everyone in, beautiful homes. You have to figure out how much things cost. But when I explain to people that it's not much cost to pay on your own and for this information to reverse a disease that you're, reverse a disease that your doctors really just are only trained to manage. So how do you finesse the getting CGMs for your patients, or do you just follow the insurance guidelines?
Well, for people that have insurance, they can actually pay $75 even if they don't have diabetes. And so I encourage them to do that. And they can actually get, I think, maybe one or two free if they go on the site. And then actually they are loosening up rules a little bit. It used to be that you had to, for Medicare, give 4 shots a day. That's
Right.
the horse is way out of the barn,
Yeah.
We want to do it before you get on a single shot a day. And so now if you're on insulin, Medicare will pay for it. You don't have to have 4 shots a day. You just have to be on insulin.
Well,
But hopefully
so imagine if you could just get they last 14 days, typically, if you just get a month's worth, you could get off insulin. I mean, with you working with somebody, okay, so you don't even have, but okay, let's say it's pre-diabetes because you don't qualify for the insulin payment by the insurance company. It's worth getting that information, isn't it?
absolutely.
Yeah.
It's pay now or pay later. And it doesn't matter how much money it's going to cost later. There's no amount of money that is going to preserve your health.
Yeah.
And many of these things are irreversible.
And the elephant in the room we haven't talked about is cardiovascular disease, atherosclerosis. Diabetes is the main risk factor, tenfold over cholesterol levels. So if your doctor isn't fixing your diabetes and they're prattling, they're worrying and obsessing about this cholesterol thing, they're missing the boat. And
the weight as well.
Yeah. Well, so I see diabetes and obesity together because the method that we use, the low-carb keto diet, fixes both. So in fact, that we were criticized in our early studies that our diet did too much. Yeah. Anyway, so now your success story of insulin reversal, please.
Oh, I just saw a patient today actually who was on an insulin pump, and within 2 months is completely off of insulin. She's lost.
But I thought insulin pumps were making diabetes more manageable, and I guess it doesn't fix it, does it?
No.
An insulin pump. Yeah.
And she also lost 34 pounds, so I was pretty excited.
So someone said to me, "You cheated, doctor. You reversed diabetes." And I said, "Yes, but you also made them lose weight." And I was like, "Yes, that's not cheating. They go hand in hand." So how is this patient feeling now?
Her life is completely different. I mean, she's exercising 5 days a week. Her husband can't keep up with her anymore. She has boundless energy, sleeping better. Again, it affects every facet of a person's life. I mean, she said, "Can I hug you?" before she left. So, I mean, that's how grateful they are. I mean, they just can't stop expressing their gratitude. Her only disappointment was that she didn't meet me 20 years ago.
Well, I know. Funny thing about time, we can't go back. But how about what was the introduction to that patient? Because often if someone has worked really hard to get the insulin control and the blood sugar controlled by a pump, they've invested so much time in this techno system that sometimes they're almost, I have to really work hard to talk them out of it, to say, no, actually, you don't need that, but my other doctors work so hard, and these other doctors they're working really hard, but misguided in not reversing it. So did this take much persuasion on your part?
It actually really did. You hit the nail on the head. I mean, I even find some people who are just, doing injections of insulin are a little afraid to give them up, especially if they've got good blood sugar control. They can't imagine that they don't need that for their good blood sugar control. And sometimes it takes a little bit of convincing. And was true with this patient as well. She was very reluctant to give up the pump, but now she can't imagine ever going back, of course.
Yeah, and it just kind of I don't understand. The next decade, I think I want to try to percolate back into internal medicine a bit, but it's been so resistant. No one's really asked my opinion for things. The endocrinologists, I don't understand. They're world experts in drugs, and they're in my building, and they don't understand food. It turns out, so at Duke, it's the NPs, the mid-levels who send me patients from the endocrinology clinic. The endos themselves, I assume it would be sort of offensive if someone fixed this disease that you've worked so hard to manage. Or I don't get it.
So I'm pretty lucky. I think I have a great relationship with most of the departments, and so they're actually, many of them are becoming obesity medicine certified, and are in fact discussing food. Yes, they do use a lot of medications, but they realize how important the food component is.
Well, then talking about other doctors and there's a bad perception that this is so difficult. I just, doc, yeah, Dr. Westman uses this diet, it's so nobody can stay on it and all this. What's your experience?
Well, you got to choose your difficult, right? So yeah, it's a lot easier to go through a drive-through. We're all busy, just, not think about it. But carrying extra weight is difficult. Having the disease of diabetes is extraordinarily difficult. So there's difficulty in anything that's, really worth doing. And it doesn't have to be difficult. It really depends a lot on your psychosocial situations. If you live in a family where, everybody's eating fast food and junk food, and you want to do something different, it can be difficult. So you have to have some support and some resources, and hopefully we're providing that to patients. For some of my patients, it's actually a lot easier. It really takes kind of the guesswork out of, what do I need to eat? I mean, here's a simple list. These are the foods that are going to make you healthier. And so for some people, it's actually easier and not harder.
Well,
And they can eat wherever they want. They can go through the drive-through. They just make different choices going through the drive-through.
so one of the things you mentioned is what I start with, which is the absence of hunger. Remember, you mentioned early on that this is a unique weight loss or diet program because there's no hunger. And so that's the way I come at it is, well, actually, if you cut off all the carbs, you take the Band-Aid off really fast, there's no hunger and it puts you in charge. I mean, you may crave for a few days, and most people don't get the keto flu. So actually, I will spend just a little time informing people on how easy it could be. Or in the intake process, if someone says, well, and my knees hurt, so I can't exercise, and so I can't lose weight. Oh no, you don't have to lose weight. And I don't like diet food. Oh, do you like bacon? And then I don't know. In Richmond, did people like pork rinds like here in
Oh
North
yeah.
Carolina? So did you know you could have pork rinds? So now I have a wall chart with the food on the wall in my office. It was a student project, and she just kind of made a research poster using the food list. And so I'll point up to the foods that you can have, and people, I can eat that and lose weight.
Can I get a copy of that?
I'm sorry.
Can I get a copy of that nice poster?
Oh, absolutely, sure. Yeah, it's the page 4 wall poster. It's 4-color, $50. FedEx or Kinko to copy it to be a poster. I'll send it to folks and they'll print it out on their color printers at home, and it's very helpful. But it also has the no-no list on it. which now people kind of self-diagnose. I come in and you know, you're at the door, and I do a lot of teaching, and I have this flow sheet where I know it's old school hard copy.
And the flow sheet.
They wanted me to get rid of that because it was not, you know, all computerized. I said, no, I need my flow sheet. I teach from it. So I'm outside the door. If there's weight loss, you know, 2 pounds per week since last visit, so 5 to 10 in a couple months, I kind of know they're following it, you know, at least some of it. If there's no weight loss, I kind of know, you know, they're not really following it, you know. So even it's success that tells me if people are doing it or not. You know, so we walk in and, you know, people know they're eating carbs. It's very rare they don't, but they might not tell me or write it down. And so people look up at the wall chart and I think I know what's going on. It's, I'm having nuts, right? So nuts are in the no box, and I don't have to go through and it takes time to kind of sleuth out if they're hidden carbs. But if people are honest with themselves, you know, they don't have addiction and denial, that chart has been really helpful to have people diagnose themselves, meaning figuring out what they're eating that is causing them not to lose the weight.
I think you glossed over it a little bit, but I think it's so important to reiterate that a low-carb ketogenic diet truly reduces hunger and cravings. And quite honestly, I do use weight loss medications in my clinic. I'd say they're absolutely as effective. I mean, a ketogenic diet is as appetite and craving suppressant as the weight loss medications,
without the nausea.
with fewer side effects.
Yeah, without the nausea and stomach pain. Well, so let's switch to that because it's on everyone's mind these days. Hopefully not our patients, although I will see people come in now for the first intake already on weight loss medicine, and they're having side effects. And they say, well, but I'm losing weight at last. I said, yeah, but you're sick all day long. So my friend who does the semaglutide in every form, and you know, pretty soon there'll be an enema, I'm pretty sure, of it, and he just hands out a prescription for an anti-nausea pill, Zofran. So it's kind of the traditional doctor teaching. You give a medicine, and when you have a side effect of a medicine, you give a medicine to treat the side effect of the medicine, and you treat the anyway. So how do you handle a first person? Let's say they're coming in, they don't know what to do, and let's say they're already on weight loss medicine from their doctor.
Well, if they come to me initially and they've not been on a weight loss medication, I always like to try lifestyle first with really intensive lifestyle training. And I tell them, look, because a lot of them are coming in asking now, quite honestly, they really are. And I say, if you reduce the carbohydrates in your diet, not only do carbohydrates put weight on you, they make you hungrier and they make you crave more. If I put you on a medicine today and you change your diet and you come back in 3 months and are losing weight and your appetite and cravings are well controlled, which did it? Now you're kind of stuck on that medicine long term. So let's try. Let's see how you're doing. You know, I do tell them if they have unmanageable hunger and cravings or really struggling to stick to the eating plan, then I will consider adding medication.
Yeah, and you mentioned the side effects. I still remember when Bob Kushner, who's at Northwestern, Dr. Kushner, he was like a kid in a candy store with these medicines finally, because he's a medicine guy. Even so, within the obesity medicine world, there are folks who focus on diet. There are people who focus on medication. And if you're a researcher, you're doing medicine research because that's where the money is, right? Like Sutton's Law. If you're going to do research, you go where the research money is. So he got up for the pivotal trials for the weight loss medicines that everyone was talking about. And he said, you know, yeah, there are a few side effects, you know, and it was 30%. So 1/3 of people drop out because of side effects. I'm like, I don't want to be involved in this. I mean, can you imagine seeing 100 people and a third of them are mad at you for using something that has terrible side effects. So why not try something? And I'm like you, I'll explain. We have diets, we have prescription drugs, we have very low calorie diets where you just drink bars and shakes for 3 months. Now, I don't have one of them, but they're available in our area. So why not start with start with lifestyle diet that is prescription strength. It's as strong as these other diet medications. But even then, so recently, someone came back and, I just can't do this keto thing. I need the medicine. And I said, well, no, just tell me what you're doing. So, again, I make people write out or ask people to write out what they're eating and drinking. And when I come in, it takes me 1 minute to know what they're eating and drinking because they took time to fill in the form. And I look at it, so it says, sandwich with keto bread. And, and it said, keto wrap and keto ice cream. And I said, well, you're not doing the keto diet that I recommended. You remember this one? And I point to the wall. I don't want you to have keto products. That's not prescription strength keto. And so she looked up and said, well, I guess I made a mistake. And those things are so expensive anyway. And so she really didn't do keto. So now the way we teach it. So if you tried
All that
something,
keto crap,
keto crack,
crap.
or keto junk food, keto
Yeah.
crap. Yeah. So the method of keto is one of the first things that I ask. Someone comes in, I'll say, well, who are you following? What type of keto diet? What brand? What influencer are you listening to? Did they use the keto diet for what you're trying to accomplish? If someone's putting butter on the steak and they're slamming in 150 grams of fat a day and they're in the gym, they're not using it for treating obesity and diabetes. So when, let's say someone is coming in and they're on a weight loss medicine and they're losing weight, but they're having side effects, how would you handle that?
Well, it depends what side effects they're having, what they've done to mitigate the side effects. But for, I am not one who will ever hand out an anti-nausea medicine. Occasionally people have a little bit of nausea in the beginning. You want, a nausea pill I don't hand them out, but if you come back at me and say, I'm having a lot of nausea right now, it's a week-long medication. You don't want them to be nauseous for a week, but if they want a continued prescription for the nausea medicine, for the to be on the weight loss medicine, I said, this isn't the right medicine for you. I'm not going to accept you're being nauseated. You have to feel well. Otherwise, it doesn't make sense. And not only that, losing weight is not the be all and end all. I think in the way we practice medicine, getting healthy is the goal. I call myself a weight loss clinic, but that's only so patients can find me. The minute they walk through the door, I tell them I'm a health clinic. If I put a metabolic health clinic on the shingle, nobody would know what that means. But that's my goal, is to get people healthy, get their vitality back, get them to be able to exercise and live the life they want to live. And when they do all that stuff, weight loss is the side effect of that. That's the byproduct. We never want to focus on the scale. It's important to know your weight so you can gauge how you're doing and be reflective on if you're doing the things you need to do to achieve that. But it's only one data point.
Yeah. I'm reminded of, so we're in the same organization called the Obesity Medicine Association. These are doctors who do this for a living. And we have to use things that work. Otherwise, no one comes back, right? So I'll explain that. And often if they're referred by their own primary care, PCP or family doc, I'll remind them, remember, your doctor sent you to another doctor. So, I'm a specialist, right? So I'm using things that will work. The other approaches that I've seen come and go, well, the very low calorie diets, you lose a ton of weight but then it's really not sustainable. So I can kind of foresee a similar train wreck that's going to happen, right? That people will lose weight with the medication and then not go back, be lost to follow-up, and no one will teach them to stop the junk food eating, or they're addicted to the carbs, and then they'll regain all the weight. And you know, the response I've gotten from people is, well, then we'll treat them then. I don't know what the other doctors that I remember, my teachers said, imagine someone's lifespan. And if you teach people how to lose the weight and keep it off using the same method, by food, by a low-carb keto diet, over their lifespan, they'll never have to lose the weight again because you taught them how to do it and sustain it. And so it might be a little slower, it's not as sexy and all that, but in the long run, it's a more wise, rational way to do it, right? To just
Well, I
use.
honestly think, because of metabolic adaptation, which means that, losing weight is not healthy if you're a caveman, right? Because that means something is critically wrong. You shouldn't lose weight. And so our bodies fight us to regain that weight because survival is the most important thing. And we still have that same kind of brain, where as we start to lose weight, our metabolism slows down, our hunger increases. And so I think eventually that's going to push against a lot of these medications. And so unless you learn how to eat to reduce your hunger and cravings, what to do when you get hunger and cravings. So I consider weight loss a learned skill. It's not just about the food. It's to also learn how to change your mindset, your relationship with food. I mean, if you think of yourself as like the best Ferrari that's out there, you wouldn't want to put junk in it, right? Like, we don't put crap in our cars and expect it to run, but we put crap in our bodies all the time and think, why am I breaking down? So
Yeah.
teaching that mindset and, teaching people about, people are making money off of luring you in to eat this junk food. So you're lining their pockets while getting sicker. And the more you start to realize that, the more you start to look at that food in a very different light. My real goal is to get people to eat the foods they love that actually love them back.
Ah, I love that. Love that. So it really is the food that's the problem. But wait, doctors don't know much about food.
We weren't taught anything.
And but it's kind of chilling to watch. Again, this train wreck, train coming down, the track is out. It's because the companies now are doing studies that after a couple of years, they're randomizing people to placebo or regular shots. And when people are put on placebo without being told how to do it by the diet, they're regaining the weight. And so they're just doing oh, well, look, that would just keep people on their shots forever. But step back, that same effect is achieved by a keto diet. You don't
And
need the drug. You don't need the drug to affect all of these hormones. And that's kind of been, when I sit back and reflect, why hasn't some researcher come and drawn the blood of our patients to figure out why it works? They're going to discover something that probably studying the brain and the regular hormones that you can test, probably going to find something totally new, or you'll find that all of it changes favorably because the hunger goes away. You start fat burning, you're eating less, you have more energy typically. Anyway, what are you excited about going forward about the research or areas? I'm kind of probing into other medical areas like the glycogen storage disease getting better, these orphan illnesses, the LVAD patients that I've had that their heart failure is so bad they have implanted pumps in their chest. You just have to be very careful about the vitamin K and the anticoagulation with those folks. But any other interesting areas well, you published on fatty liver.
oh yeah, one of the things that's known about fatty liver is you need more of a weight loss than you do to help start reversing some other conditions like diabetes or high blood pressure. For fatty liver, especially if you have fibrosis, you need to start looking at a 7 to 10% weight loss rather than just a 2 to 5% weight loss. Yeah, so our patients we've studied with fatty liver, and they've had dramatic improvements. And in the fat in the liver seems to reverse very, very quickly. Fibrosis, as you can imagine, that's a more tough kind of actual fibrous tissue, takes longer, but we do see it as well. So, and up until last week, there was absolutely no treatment for fatty liver other than by losing weight.
I had a patient through the years who was an ultrasound tech. And so she had the ultrasound machine every day, and she had fatty liver. So she just scanned her liver, and within weeks, it was gone. It was a mild form. But so weight loss, and especially a low carb diet for weight loss, fixes fatty liver, which I'm kind of astonished. It's one of the main causes for liver transplantation now.
Number one in women.
And it's all from the food. Yeah.
The problem is, here's a huge problem. Patients come to see me and they say, I have a fatty liver. My liver doctor told me to come. And then I tell them to eat this diet, which is higher in fat than they're used to. Like, well, isn't the fat going to cause my fatty liver? It's really unfortunate that it's the same word, because it's really, and then I always tell them about pate. I'm like, pate, the little stuff you put on the little toast there, that's the fatty liver of a duck or a goose. And they don't feed them fat, they feed them carbs.
Corn.
So, but I think two important things. One is that we haven't talked about is a lot of things reverse or get better before any weight loss at all. Like my patient who was off 53 units of insulin, she hadn't lost an ounce yet, really, in 4 days. So it's not the weight loss that's causing the improvement in these conditions. I have a patient, patients with psoriasis, patients with asthma say the same thing. Patients with arthritis, they haven't lost any weight yet, but their knees feel better.
Yeah.
And they can walk. This is, people say, I want to learn about an anti-inflammatory diet. I'm like, take out the inflammatory carbohydrates and you've got it. So I think, you said, what else am I excited that, these low carb ketogenic diets, where we should look for research. A lot of people are coming to me now saying that they read something that maybe it's going to help with Alzheimer's. So a lot of neurological disease, Alzheimer's, Parkinson's disease, multiple sclerosis, migraines. And of course, like you said, one of the first use cases for a ketogenic diet was for seizure disorders. So there's always been some type of neurological signal there. And, we call Alzheimer's disease type 3 diabetes. And so people are coming to me to try and see if this is going to help them. And certainly there's emerging evidence in a bunch of neurological types of diseases. And then, so many other indications other than just the neurological diseases. Cancers, cancer loves sugar. What's a PET scan? To look for cancer, we put radioactive tracer on sugar molecules, and the sugar molecules go to where the cancer are. So they're using ketogenic diets as therapy along with some conventional chemotherapy to improve remission rates. So, a lot of this is still in its infancy, but there's something very special about a ketogenic diet. There are some very active molecules which do a lot of things that we don't really completely understand at this point.
I think it's like a smartphone. When it's low on energy, it goes into safe mode. When a human, a mammal, doesn't have energy around, it starts burning its own fat. And I'm beginning to believe it's going into safe mode. It's not a self-destruct mode. I was looking at my phone, it said 20% battery. Do you want me to go into self-destruct mode? I kind of had a hallucination, and I was like, wait, that's not ketonemia, being a fat burner, isn't the self-destruct mode. What evolutionary pressure would keep organisms from, self-destructing all the time when there's no food. So I'm beginning to think differently about this, that there are going to be some economies that we find. There's going to be, and in regard to those two situations, Alzheimer's, best I can tell, has about a 20-year gestation period, if you will, where you want to start making changes before you get symptoms, for sure. So if you have a parent who has Alzheimer's, you want to take action now. And the best research, the biologics research that's being done is on the keto diet for Alzheimer's. And no, there aren't clinical trials of reversal and all that yet, but insulin resistance is coming out like this strong signal for Alzheimer's. So that would be a time to take action. And I would say even now, it's not harmful to not eat carbs, ever. You don't really ever have to eat carbs. And Jeff Volek recently at a meeting reiterated that. He said there's no evidence that being in ketonemia, ketosis, is harmful. And that made me reflect back. The only paper I did with Jeff Volek was initial studies when we were trying to look for evidence for low-carb diets. We published this like in 1998. Reflecting back, where were the studies that showed a low-carb diet was bad? There were none. And yet I didn't even remark about that. I had a friend who said, where are the body bags? If everyone's doing Atkins and it's killing you, there should be body bags in the ER, like COVID, but there were never studies. It was all just a belief system, a paradigm view, or you could say it was just a limited view, and now we have new knowledge. But for Alzheimer's, you want to take action as soon as you can if you're high risk for that, for sure. And cancer, a couple of weeks ago, someone came in with a metastatic thyroid, anaplastic thyroid carcinoma. I was, why? I don't know why are you? Well, he was a seeker. He had local university therapy, then went to MD Anderson and got onto another drug, and he had a stable disease, which I had to retool on this. It's not stable. It's very aggressive, so I go Googling, PubMeding in the room, anaplastic thyroid carcinoma, keto. Oh, why not? Click. 2 studies popped up. There's a University Harvard surgeon who does an animal model and shows that there's a reduction in growth for this tumor in the animals. And so I email him the next day. He says, "Oh, Dr. Westman, I've heard of you. I know your work. My wife went to a meeting, heard you talk, and then got onto keto. It changed my research." And his area as a surgeon is this aggressive type of tumor. And he said, "Yeah, we know this tumor is very glycolytic, meaning it uses a lot of glucose." And getting back to that PET scan labeling to find metastases for glucose, metastases for cancer with that glucose molecule, it's going to be interesting to see. I mean, I can't keep up on all of these things, but and that's not proof that this guy is going to be better. I'll never say that, see there, you don't need your traditional therapy. Of course, you always want to do traditional therapy with cancers. I don't have the evidence to say you don't need that, but I bet there'll be specific tumor types where using keto as an adjuvant will be helpful. Or who knows, maybe as the only treatment, but we're not there yet. Yeah, it's exciting to see. Jeff Volek is doing a lot of cancer research now, and he's less of the surgeon at Harvard with the animal models, but Dr. Nez, N-E-H-S, is the researcher there. So I'll go to Google University, PubMed, the database where published papers are, to see the latest information, and I hope it's going to explode. Have you had experience? Oh, but so this tumor has been stable. They're following it, they're treating it. And Dr. Nez said, yes, I have some patients who seem to be outliving the prognosis for these tumors. And the first time I saw that was with the glioblastoma multiforme, the GBMs. There was a presentation that just about everyone had this
It's a
kind of
brain tumor
disorder.
for the people listening.
Thank you, brain tumors, and they outlived, but it didn't. Best I could tell, finally people succumbed to it. But gosh, if you could add a year of life to somebody, that's huge, right? So,
Yeah.
what's your take on the cancer? Have you had any patient experiences?
I get a lot of people who have had breast cancer who are sent by their oncologist because they know obesity is a huge factor in recurrence, and actually initial breast cancers as well. I can't say that I've studied it and say that, it saved anybody from metastasis. It's hard to know, the null effect, you don't know what would have happened if they hadn't changed their diet. But most people feel better and can exercise more, and exercise is also something that really helps reduce the rate of recurrence. So, I mean, people feel better. Isn't that really what it's all about?
Yeah, well, I think our job is to help people have happier, healthier, longer lives, right? If you live a long, awful life, if we give people more terrible years, that's not my goal, right?
Yeah, actually, that reminds me of something that I do with patients all the time. So, unfortunately, I don't know, can you see that?
Yeah, a curve going
So,
down,
yeah,
or
so this is the way, let me see if I can go backwards here. So this is the way I think most of us live our lives here, where every day you're kind of sicker than the day before, right? But nobody really wants to live their life like that. This is the way people want to live their life. The top line here, where you're well every day, you feel great until the day you drop dead. And honestly, what's in this triangle right here, as far as I'm concerned, of course, genes play a role, is lifestyle, diet, and exercise.
yeah,
Getting good sleep, managing your stress, all of those lifestyle things, I feel, are the difference in those two lines.
yeah, that very well put. And when you look to other people who've had long, healthy lives, you want to be Jack LaLanne who's exercising every day in his late 90s rather than someone hunched over in a wheelchair if you can. So that's a great way to put it. Now, we could talk for hours, but
And we do.
I get the feedback that I shouldn't go on too long, but how would you summarize your experience with the low carb diet, and then how do people find you if you want more patients?
So we always love patients. We find some way to make it work. The low carb diet has transformed my life, the life of my patients, life of friends and family. They see what we're doing, and they adopt it as well. And people feel better, live. I'm healthier now than I had really been in my life. And I really credit that with the way I eat and exercise. Um, so, I mean, you really have little to lose, right? And you can even do this on a budget. A lot of people think that eating a low carb diet is so much more expensive. It doesn't have to be. There are lots of resources on how to do this, shopping at the dollar store. So there are definitely ways to do that. But even if you think it is more expensive, I mean, it's pay now, pay later, right?
Yeah.
So you don't want to pay with your health, because that, oftentimes is, there's no going back when some of those things happen. We would love to see everybody. You can just Google VCU medical weight loss. I can give you the phone number directly. I'm only
Please.
licensed in the state of Virginia, so I can only see people in Virginia. But we do telemedicine. We ask that people come see us for their first visit. And then they can we can do telemedicine after that. We do a free informational session once a month. And if they just call 804-828-0761 and get set up for the informational session, they'll learn a lot about, we talk about the disease of obesity and the treatments, both medical and surgical.
Fantastic. And again, you're in a university system, Virginia Commonwealth University in Richmond, Virginia. And this isn't some fringe mom and pop shop out in, this is a growing trend because it works. I mean, back in my undergraduate days, I read a book called The Scientific Revolutions and How Paradigms Shift. It's a slow process, and it's one of the reasons paradigm shifts is that the new way of doing things fixes things that the old way of doing things couldn't. And the techno people like Dave Feldman, who's doing the cholesterol study, looks at me in disbelief, says, why don't doctors change? I mean, we do something new every year. There's a new code that comes out, or the computer is so evolving. And I don't know. We have select out people who will follow the herd mentality, perhaps. But if you want results and want to fix people just by using food, this method is fantastic. It changed my life too. I had no idea I'd be prescribing pork rinds to people to reverse their diabetes. There's a family that drives up from Charlotte, the area, just to get the fresh pork rinds made near my office. And then they'll drive back, well, and visit me in the clinic. But so you're in the insurance pay system?
We are. We accept all insurances in the state of Virginia. We accept Medicaid, Medicare. We even have a financial assistance program. So I think that's also, I mean, one thing that sets, I think what we both do apart from many of the others is that we take insurance, and we're both internal medicine doctors. And those are doctors that are used to taking care of very sick patients with a lot of medical problems. So we're very comfortable with all of the medical problems people come to see us with.
Yeah, well said. And there are some obesity medicine doctors that kind of skim the worried well, who just want to lose weight, and there really is no medical issue that I'll say is too complicated to change the food, to cut the carbs. It's just you might need more monitoring. But even then, I took someone off insulin watching the blood sugars by my phone, by just a text a day. Well, are you optimistic that the medical world will come around, so to speak?
I really think it's happening. And I think, I would be remiss if I didn't say that you're one of the major reasons why that is. I mean, when I met you 11 years ago, I don't know that you were quite as optimistic, but I think the low-fat diet is dying its death. It didn't work. It made people hungry. And I think, the Journal of American College of Cardiology in 2020 came out with this big, reassessment on saturated fat. I'm not sure a lot of cardiologists have read it, but it sort of gave me, really good, affirmed what I am doing. And I thank you for it. I mean, honestly, most of the world should thank you for it, because there is a different way. And I think the tides are turning.
Well, it does take some perspective, though. Old saying that in the scientific world, things change one funeral at a time, meaning that people are entrenched in an old way. It's hard to get it. But I think the internet and the social media, it's a blessing and a curse. But I think effective information will be found, and people will go. They won't hit against the negativity that kind of has been there all our lives. That's my hope. Thanks so much for spending some time with me and with our folks. And again, I'm just so thrilled to see how you've been successful through the years, and look forward to seeing you again very soon.
Always a pleasure.
Thanks, Ken.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.